Thank you very much, sir, for that very kind introduction. And right at the onset, I'd also like to thank Dr. Sanjay Kalra, Dr. Krishnan, and all the members of the Endocrine Society of India for having given us this platform for conducting the Obesity Week and for having me here for this particular talk. Over the next couple of minutes, I will take you through the role or the utility of meal replacements in the management of obesity, some of the insights that we get from the obesity clinic that we have here at CMC Vellore. So in this talk, I would try and answer three questions: the why, how, and what. So we'll talk about why meal replacements are needed in our clinical practice, understanding how it really fits in the algorithm of managing obesity, especially in the Indian setting. I would also talk about how it has to be, used, the science, the availability, indications, pros and cons. And the third question would be the most important: what is the evidence to support it? The evidence that is available across the globe and more specifically from the Indian subcontinent. So starting with the first question as to why meal replacements are needed. And over the years, definitely our understanding of obesity has changed. Today, we stop looking at obesity as just mere numbers of BMI or just numbers of any kind of waist circumference, but we give it a more holistic view. And one way of doing that is by looking at different staging systems, which are more clinical, which just not encompass the anthropometric parameters, but look at the physical, physiological, and the functional aspect. And why these classifications are really, really helpful is because overall, they tell us much more about mortality. Now, in this data, we see when we follow up these patients over 20 years, and if I was just to look at BMI, I wouldn't be able to pick up a patient who's going to be at more risk for mortality, unlike these systems. But then this is really endorsed by the most recent guidelines. I think the most recent obesity practice guidelines are from the Canadian Obesity Network, published last year in August. And they highlight this, and they do mention about quality of life and patient health outcomes. But when we are looking at our Indian patients, and we're looking at the health-related quality of life. This is data from our own multidisciplinary bariatric clinic here. And what we find is that majority of our patients have a poor health-related quality of life. Now, what has this got to do with meal replacement? So when we look at quality of life and we see why people have poor quality of life, we see that the two important factors that really stand out are the comfort with food experience and the experience with dieting. Now, these are the two factors that really pull down a person's quality of life. Looking at this a little more in depth, what kind of words really stand out when we're talking of diet experience? People tell about deprivation, frustration, tiring effects. They make me feel unwell. They make me feel guilty if I overeat. So there is a definite unmet need here in our dietary prescription when we're talking of improving quality of life. We need something that's simple so that it's not frustrating for the patient. It should be easy to use. It should be nourishing. It shouldn't make the patient very tiresome. It should be scientifically apt, well balanced, and it should be a low calorie meal so that overall the patient does get a benefit. Not only this, when we look at the other aspects, the psychological aspect, we find that in our Indian patients, a lot of them either have this binge eating habit or grazers. Grazing means they'll be eating something or the other all throughout the day. So our dietary prescription fails to provide satiety, and this is another unmet need that we have today. Not only this, when you just look at the dietary recall from people who have morbid obesity, the other important aspect is despite many of our patients taking large amounts of calories, many of them are still protein deficient. And that is very important for getting a good appetite suppression. So overall, cutting a long story short, what is the unmet need in a dietary prescription today is that we need something that can improve the quality of life, which is simple and easy to use, is scientifically validated, is well balanced as a calorie. It ensures good protein intake and provides good satiety. And I think as a meal replacement therapy, this unmet need can be well addressed. So that answers my first question as to why is this needed. I move on to the second part of my question as to how this works. What is the science and the availability? Now, when we look at PubMed and we do a search for meal replacement therapy, as of today, there are only about 530 publications. A lot of them have happened in the recent years, and that's essentially after the direct study. But then the first paper probably goes back way back in 1983. And at that point, they were thinking of protein powder or treatment of obesity. But the research on that was very minimal. And it is only essentially after this famous Banting lecture by Professor Roy Taylor sometime in 2012, 13. And that's when he described the twin cycle hypothesis. And that's when very low calorie diets actually gain momentum, because it's just not only talking about weight loss, but also reversing diabetes. And that's when meal replacements really took into place. And then we do understand the pathophysiology of how they reduce the fat in the liver, the fat in the pancreas, and how they improve the metabolism. So overall, understanding the concept of meal replacement therapy, essentially we ask our patients to skip a meal, and instead of a meal, we give them a pre-packed meal from the pharmacy, which may have about 15 to 20 grams of protein that make sure the satiety is taken care of. It has only about 150 calories, but the most important, it is not only the macronutrients, even the micronutrients. And I think in some of the latest newer meal replacement products, just even is looking at ICMR data and looking at 50% of their recommended dietary allowance. There are two types of meal replacement therapy that can be offered. It could be partial or complete. Complete means all the meals are replaced in a day, whereas partial would mean that only one or two meals are replaced in a day. When I was doing an observership at the University of Alberta, they used to give all the 4 meals replaced, and the patient would come back after 3 months or 6 months after having lost 20 to 30 kg. But that doesn't really work very well in the Indian setting. I feel food is a very social thing, but going slow and steady is helpful. So maybe replacing 1 or 2 meals, especially for many of the housewives who come and seek treatment, it's helpful. So the key advantages are that there is calorie restriction, good protein content, therefore it's just providing good satiety. It's good micronutrient cover. It's very easy to use. Many patients who are staying in the hostel, they will come and say, doctor, we are dependent on mess food. How do we really go about making sure our calories are reduced or the oil content is reduced? So it's easy, and it just shifts the focus from the doctor to the patient and makes it more patient-centric. It gives the ownership to the patient to handle their calorie intake. Yes, there are disadvantages. What's not so good is definitely the cost in the Indian setting, and I'm going to show you the evidence that's available. It's not 1 year, 4 years evidence is available in some studies, but then even more long-term data at this point is required. I'm not here to suggest any particular brand or not brand, but I think as physicians, we just need to be sure that we're giving adequate calories and at least a good amount of protein, at least 15 to 20 grams of protein to provide good satiety. So where this will fit in our treatment algorithm, somewhere after lifestyle change. In practice, what is recommended is not to give meal replacements upfront when the first day the patient is coming to see you. It should be first always the basic lifestyle and the dietary and exercise advice. And once the patient starts losing weight, I'm sure the patient will come back after 3 months and tell you, doctor, I have done this, I've lost 5 kgs and I'm not losing anymore. And I think that's the point when you add this, that gives you an added benefit of weight loss. And that's where this finds its place in the algorithm. If you look at the EOS staging, somewhere in EOS stage 3, and believe me, there is no dearth of patients. This is data again from our own center, where maximum number of patients actually fit in EOS stage 3. Yes, ours is the tertiary care center, and there is referral bias, but yes, EOS stage 3 is somewhere that we would like to use meal replacement. Looking at the guidelines, again, this is a very strong statement from the CMAJ directly that partial meal replacements are not only helpful for reducing body weight, also shown to reduce waist circumference, blood pressure, and improving glycemic control. But the important point that we read in between lines in this guideline is that it's just not one meal replacement that you talk about, just not prescribing it like any other medicine. It has to be coupled with a nutritionist advice, psychological advice, counseling for exercise. All 3 need to be done together to get the best response. It's just not one simple tablet prescription that really works. So adding other pharmacotherapy or surgery over time has also shown better benefits, and I'll show you the evidence about that. So far we've seen why is this needed, how does it work? Let's look at the evidence. Now, one of the important studies, and especially from the US, where Optifast is a common meal replacement that is used. In this particular study, they looked at almost 300 participants, about 280 participants with a BMI of 30 to 55. spanning across the age of 18 to 70 years, followed up for 1 year. They looked at their body weight, they looked at their body composition, and found that if you were using meal replacement as compared to conventional dietary advice, these patients did lose significant more amount of weight, not at only week 26, but even at week 52. After this, a more detailed analysis, which this was published with respect to the health-related quality of life of these patients. And again, in the same program, the health-related quality of life was much better when they used meal replacements as compared to conventional diet. This paper was just published last week in the International Journal of Environmental Research. Talking about meta-analysis, this was somewhere early in 2003, where they looked at 6 analyses, again comparing partial meal replacement as compared to conventional reduced calorie diet. Again, overall, not only the meal replacement provided more weight loss, but then the standard deviation was much less. So more likely that most people would benefit, unlike in the routine reduced calorie diet, the spanning range was as low as 3% to 7% weight loss. A more robust analysis, and this was published 2 years ago, 23 studies, 7,800 patients, comparing again meal replacements versus conventional diet, definitely more weight loss at 1 year follow-up. So the big question that often remains is, okay, meal replacements are good, they're easy, maybe if the patient can afford, we can prescribe, but what happens after 1 year? Most of the studies have been for 1 year, but there is emerging evidence for even long-term studies. This was one that was published for a 3-year outcome. And what it clearly tells us is that those patients who really follow with us at a long-term point, so they would have sustained benefits of meal replacement, but those who get lost to follow-up, even though they did an intention to treat analysis, but those who were lost to follow-up are not likely to maintain their weight loss. So like any other chronic disease, like diabetes, like hypertension, we need patients with obesity to follow long-term to make their sustained benefit. Talking of data from India, one of the early studies was from Dr. Anup Mishra's group, a 12-week randomized controlled study, 122 men. But what they used here was a bit of high protein. They went up to high as 28%, so that's definitely more. But they did find significant benefits even in the Indian population by using this meal replacement. Another important study, and this was one of the first studies, which was looking at reversal of diabetes from Dr. Unikrishnan's group, led by good friend Anjali. 12 patients followed up for 12 weeks, and a very systematic, simple dietary plan, which can be easily followed, where 2 meals were replaced by a meal replacement. Yes, 50% of these patients had remission in diabetes. Another large study from Dr. Neeta Deshpande's center in Belgaum looked at 72 patients. And the interesting concept here was that it was just not the weight loss or the anthropometric parameters that they're looking at, but then it was the other metabolic parameters as well. So it's just not reversal of diabetes, it's reversal of metabolic parameters. So definitely there is good enough evidence emerging even from the Indian subcontinent that there is a good impact of meal replacement therapies. So to conclude, in interest of time, I will go back to the 3 questions that I started with. Why is meal replacement needed? Yes, to improve the diet experience, which in turn improves health quality, improves the protein intake, and therefore improves satiety, and therefore meets the unmet need of a easy, good, effective diet prescription. How does it work? Yes, we know how it works as we've learned from Dr. Roy Taylor's work. There are 2 types, partial and complete. Yes, there are advantages and disadvantages that we looked at. Yes, it is endorsed by international guidelines. The evidence, there is evidence in individual studies improving health-related quality of life. There's a meta-analysis that tells us there's long-term follow-up up to 3 years as of now that is available, and there is Indian data as well. So I'll stop here, but we'll be happy to take questions. I do acknowledge our entire team of the pediatric clinic, my mentors, Professor Thomas Paul, Professor Nihal, Dr. Simon, our psychiatrists, our pediatric surgeons, and our dietitians. Thank you very much.